Good evening, everybody, and welcome to this evening's Hepatitis C Case Studies for General Practice webinar. My name is Samantha, and I'm your host for this evening. Before we jump in, I would just like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Okay, so I'd like to introduce our presenters for this evening. We're joined by Dr. Joseph Lawler and Dr. Mari Healy. Joe was awarded his medical degree from the University of Sydney in 2004. He completed his advanced training in gastroenterology in 2011, having trained at RPAH and Liverpool Hospital in Sydney. He completed a clinical fellowship in liver medicine and liver transplant medicine at the Mount Sinai Hospital in New York City in 2014. He is now a consultant gastroenterologist and hepatologist in Central Sydney and Western New South Wales, LHD. And Mari has been a GP in Redfern for more than 20 years with experience and interest in aged and chronic care and Aboriginal health. Mari has also been an RAC GP examiner and QA examiner for 15 years. So thank you, Joe and Mari, for joining us this evening.
Thank you. Hi,
Thank
everyone.
You. Hello, everyone, again.
Wonderful. So I'll hand over to Mari now, and she'll take us through our learning outcomes for this evening and then jump into the presentation.
So hi, everyone. By the end of this activity, you should be able to firstly order and interpret tests necessary to diagnose hepatitis C and prepare patients for treatment, recognise risks, signs and symptoms of liver disease and other comorbidities that require management or referral to specialist care, and choose appropriate hepatitis C antiviral therapies according to virus genotype and potential for drug-drug interactions. So we're going to try our best to cover those three learning outcomes. Here are the three cases we'll be following in the context of our learning outcomes. They reflect a range of presentations that we as GPs can expect to manage. With access to great therapies and clear guidelines, GPs can feel confident that they have the skills and resources to cure hepatitis C across many scenarios. So we've got Ahmed, who's a 52-year-old male originally from Egypt, Joe, a 63-year-old man with abnormal liver function tests, and then two, a female 32 years old of Vietnamese background seeking treatment. So we'll progress to the first case, who is Ahmed.
So yes, Ahmed is a 52-year-old engineer who was born in Egypt, and he presents for the result of his hepatitis C antibody test after he had a medical checkup recently. Also of note was that his father recently died of liver cancer in Egypt. He has a past medical history significant for hypertension, dyslipidemia, reflux, depression and erectile dysfunction, and his medications are listed there. There is no history of alcohol or smoking, and his BMI was 23.5 with a blood pressure of 134 and 76, and he was found to be the anti-HCV antibody positive. His examination was otherwise normal, and he has no signs of cirrhosis. So we have a gentleman here with a significant country of birth, given the priority populations we've identified in the past, understanding that Egypt has quite a high prevalence of hepatitis C. We also have a history of his father having hepatocellular carcinoma, which is a bit of an alarm bell and sort of expression of his risk of liver cancer. And we also know that he has exposure to hepatitis C. So as a GP, Mari, how would you proceed in this situation? And we can give everybody an opportunity to think about this before we go to the next slide.
Yeah, well, already I'm thinking we've got a middle-aged man with a significant history. He's from a high-risk area. His father died of liver cancer, and he's had exposure to hepatitis C, obviously, because of the hepatitis C antibody test. Yep. And I do note the presence of several comorbidities and medication. So I think we're going to need a systematic approach to assessing this man with a view to finding out where his liver is at and what we need to do about it. So I guess one of the first things I'd ask myself is, does he actually have current hepatitis C infection? So we need to check for hepatitis C RNA. In other words, need to check for viremia. So here we have hep C RNA, which tests for actual active infection. So if it's positive, a quantitative hep C RNA and genotyping can be done. this is useful for prognostic reasons, although essentially it remains a Medicare requirement as well. Does he have significant co-infections? I'd have to ask that because, you know, if you've got hepatitis C, have you got other infections?
Viruses,
Yeah, that's it. So, and if he doesn't have them, it'll help us decide what vaccinations he needs.
Absolutely.
So checking for hepatitis B, hepatitis A, and HIV. So active hepatitis B, I understand, requires specialist treatment, so I'd be sending him off to you, Joe. Otherwise, I would offer vaccination if he's got low or absent immunity. Hepatitis A is really common in childhood in this age group, but if he comes back negative, just offer vaccination. Obviously, people don't carry hepatitis A. So HIV, again, if co-infection is present, well, that becomes a lot more complicated. So that requires specialist treatment and lots of work there. The baseline tests that we do want and looking for comorbidities are the blood count, liver function, urea, electrolytes, the INR. These are all, and the full blood count, all important in the assessment, firstly, you know, for cirrhosis and comorbidities. Also the alpha fetoprotein, because his father had liver cancer and abdominal ultrasound.
To check his, that's right.
So here are his results. So they're quite interesting. He does actually have active hepatitis C. He's got positive hepatitis C RNA and he's genotype 4. It looks like he's got past resolved hepatitis B and A. You can see the negative antibodies, and he's got the negative core antibody for hepatitis B and a positive surface antibody. So that's a good result. The liver function tests I can see are normal, but the full blood count are not normal. I'm sorry about that. They're not normal, and I guess you'd be thinking that might be because of his positive hepatitis C.
Yeah, so the ALT and the AST are just a little bit up.
Yes, but reassuringly the full blood count and INR are normal, but he certainly does need further assessment for fibrosis or cirrhosis, given those abnormal LFTs and the positivity of the hepatitis C infection.
Yeah, so as you pointed out, the fibrosis and cirrhosis assessment is a really critical part in this pathway to treatment in general practice. So the degree of liver fibrosis is important as a prognostic factor for progression of disease or clinical outcomes. And assessing fibrosis informs us as the treatment urgency. So if there is significant fibrosis or cirrhosis, the urgency to treat is now. It also indicates needs for additional screening. If you are concerned about cirrhosis, those patients need to be assessed for liver cancer, as we've discussed, esophageal varices, and other complications of decompensation. It also determines, in some cases, the regimen you would choose to treat in terms of hepatitis C and the duration of treatment. And it's certainly required by the PBS4 prescribing. It also dictates the post-HCV clearance management in these people.
Yes. Okay, well, look, we might continue with how we're going to assess the fibrosis and whether it's significant or present in this man. So obviously it involves consideration of several factors. While the gold standard is liver biopsy, really a comprehensive approach is generally used, as illustrated on this slide. It gives the clinician a good indication as to the stage of fibrosis and the presence or absence of cirrhosis. So I guess in your experience, Joe, biopsies are left for cases where it's more complicated or you haven't got a clear picture in the end after this. But this would give a pretty good indication in most cases.
Absolutely, yes. And we should stress that liver biopsy is definitely not required to treat hepatitis C, and it hasn't been a requirement for more than 10 years.
Yes. Yeah, so obviously taking a history, doing an examination, the non-invasive tests and the laboratory investigations are all part of that comprehensive assessment of fibrosis. We have covered that in previous webinars, but it's just good to go through it again. So, Joe, this is the the fibroscan that I've gone ahead and organised.
Yeah, so this is transient elastography, which gives us a non-invasive and painless indication of how stiff or hard the liver is, and reflects on the level of fibrosis. So he's had a reading of 6.8, which is pretty good, but as you can see, it's on the cuff there, and it might suggest that he has early fibrosis or even none. So there's no indication to refer this gentleman on to specialist care. It's perfectly reasonable to treat him in general practice, and he does not need to be screened for those other complications of cirrhosis, such as varices.
Yes, okay. But we've also done the ARPRI score, so we've used this non-invasive calculation on figures that we've already got there.
Yeah, and this is a really important test to be aware of, and it's available online for free, and you can have it as an app on a smartphone, because you don't need to have access to FibroScan in order to treat hepatitis C, but you do need to have some form of assessment, and you can utilise all of those, the history and the biochemical findings and the full blood count to make a decision with the assistance of a tool like this. And it uses commonly ordered tests like the AST and the platelet count to give you a value, a ratio index that can sort of make cirrhosis less likely or more likely. So a score of less than 1 is what we'd see acceptable. And in Ahmed, this is consistent with his FibroScan assessment.
Okay. So also we organised an ultrasound.
Yeah, and look, I think this is important in Ahmed's case, particularly given the family history of liver cancer. But remember that with hepatitis C, you do need cirrhosis to be at risk of hepatoma. But given that family history, the screening was warranted. But remember, you can also utilise the ultrasound findings to help you in your assessment for cirrhosis. So this report is that the liver and spleen were completely normal. So no imaging evidence of cirrhosis and no imaging evidence of hepatoma.
Yeah. And you often get a report that says, the spleen's not enlarged,
That's right,
and that there's normal portal flow and other things that
can't see any varices. Yeah, all those
Yes. Okay then. All right. So let's summarise what we know about Ahmed then. So he's a man that had a screening test and was found to, on the checkup was found to have been in contact with hepatitis C. He's got chronic hepatitis C infection and with no indication after comprehensive assessment of cirrhosis. His comorbidities are hypertension, dyslipidemia, so that metabolic sort of stuff, reflux, depression and erectile dysfunction, no co-infection that we've found. He's on several medications. He's had no previous treatment because this is a new diagnosis for this man. Cirrhosis screening is not indicated because he's on comprehensive assessment. He's found to have minimal or early fibrosis.
Yeah, that's correct.
And so he can be treated by the GP. So let's see what we need to consider. So what are his treatment options? We need to look at what we're going to do, and I think obviously we're going to offer him direct acting antivirals. But we need to consider his medications and other things, and other factors to consider is treatment history and adherence. So is he interested in treatment?
So we've got a gentleman with no cirrhosis with genotype 4 infection, and we'll go back to the table that's available through the GISA website, and this is all reproduced on a wall chart which provides a quick and easy access summary. So given that this gentleman has genotype 4 infection, he can use the two pan-genotypic, in general practice you can use one of the two pan-genotypic regimens available with the sofosbuvir and valproatovir or Epclusa, or the glicapavir and pibrentasvir, the Mavorite. He will also qualify for Zepatia, the elvisvir and grisoprevir. So there's quite a few treatment choices there.
Yeah, and you've just for that second one, he can have 8 weeks of treatment.
That's right.
If there's no cirrhosis, so that looks pretty good too. All right, great. So look, he's on a few medications, and there's this tool to help us to look at drug-drug interactions. So you can enter your medication into the tool, enter all the other medications that he's on, and review the interactions. So all you have to do really is add the information, and they come up with a table of what's a safe.
So in this slide, I mean, we've got on the left-hand side, we've got all of his co-prescribed medications, and then as we move across to the right, there are the 3 available medications that we could prescribe to this gentleman. And you can see that the elbasvir or gazoprovir, the Zapatier combination, gets the green light all the way down his current medications. And just to point out, that doesn't necessarily mean that that's the only choice. On the website, you can click on those orange squares and the yellow triangles, and you'll come up with prompts. And there are strategies to get around those warnings. So, for example, with statins, often you can suspend treatment for the period of treatment. For rabeprazole, often PPIs can be stopped and use non-pharmacological methods to deal with reflux. Just the easiest pathway here is to use Zapatier, but you could get around the issues with the other 2 options as well.
Yeah, sure. Yeah, so you've got options there, definitely. So look, these are the PBS population and treatment criteria in the general statement for drugs for the treatment of hepatitis C. So you can see that patients must be over 18, treated by a doctor experienced, where you can treat and gain experience along the way, as we have discussed in previous webinars. There's the information you must provide on your application, the genotype of Hep C and their serotic status, and in this case he is non-serotic. And you must document in your medical records evidence of chronic hepatitis C infection, which we have, and evidence of the genotype. So it's pretty straightforward. And if you're gaining your experience, there are special forms that you can use to submit to the specialist. It gives you a bit of a summary that you can keep in your file of your assessment and management plan for this patient. But you can also develop a good relationship with a hepatologist, such as I might have with Joe, so that where I could contact him by phone, describe the case, and I could be supervised that way too. So you can work up a working relationship with a specialist too to gain your experience. So there's a couple of ways of doing it, but that's sort of a systematic way that people, can certainly use.
So he's been treated with 12 weeks of elbasvir and gazoprovir. In terms of monitoring, in September last year, the GISA revised their recommendations for on-treatment monitoring, and they basically removed any requirement for on-treatment monitoring for non-serotic patients being treated with DAAs.
Yes, because they used to say LFTs halfway between or something, or 4 weeks after
week 4,
or something.
And then nothing till the end. Then you do them at the end of treatment, and then 12 weeks after. But now it's been really simplified. So now we only have to test people 12 weeks after their treatment completion. Okay, and that's really to assess cure. There's a caveat to all of that if you're concerned about compliance and things like that, you can do liver function tests and monitor viral loads on treatment to check on compliance. But if the treatment is fairly straightforward, there is no mandated monitoring on treatment, because these medications come with so few side effects, and they are effective.
So basically, you're in treating this man, you're working him up, assessing him, and you're really involved in that hepatitis C care and monitoring and treatment for 6 months, because he'll be treated for 3 months, and then after another 3 months you will check for sustained viral response, which is cure, and his LFTs again. All right then, good. So, does he require ongoing liver cancer screening after he is cured of hepatitis C, Joe?
So no, because we did our pre-treatment assessment and found him to have no evidence of cirrhosis. Because as he doesn't have advanced fibrosis or cirrhosis, he doesn't need to be monitored for liver cancer onwards, nor be assessed for complications of cirrhosis.
So even though he's got that family history, we're maybe presuming that his father had
Had
cirrhosis and hepatitis C.
C.
Yeah, yes. Okay then. All right. So we might go on to the next case. Now, here's Joe. Now, Joe was diagnosed with hepatitis C 3 years ago via pre-operative screening. He's a 63-year-old Italian builder, emigrated to Australia aged 25, married with 3 children, 4 grandchildren, and a couple of years ago he was diagnosed when he was screened before coronary stenting. So he was found to have hepatitis C antibody positive and mildly abnormal liver function tests, which have been slowly declining over years. There's no obvious risk factors for hepatitis C, and he's had no previous hepatitis C treatment. So we've got a man who was diagnosed about 3 years ago just through pre-operative screening. So now, here's his past history. So looking more at Joe in detail, hypertension, he's got diabetes, ischemic heart disease, he had coronary stents, as we know, he was worked up for those, dyslipidemia, reflux, depression, chronic back pain from prolapsed discs, osteoarthritis, osteoporosis. Look, we see a lot of chronic disease in general practice. This shouldn't scare us.
No.
We've got a lot of people on a lot of medications and with a lot of comorbidities. You can see his medications there. It's on that sort of metabolic pathway he has here with all of those medications. He does drink 200 to 240 grams of wine weekly, and he smokes 10 cigarettes a day. So he's got significant comorbidities and a high medication burden, and has the added risk of regular alcohol intake. So what are we going to do with Joe? Well, we'll have a look at him, examine him and see what we think. His blood pressure there, it's a bit elevated, as is his body mass index. It's in the obese range with central adiposity. So it does make the abdominal exam difficult, but you can't detect hepatosplenomegaly. There's no signs that you can detect of chronic liver disease and no signs of heart failure. So I guess that's a little bit reassuring.
So what would you do now? What other tests would you like?
Okay, well, look, again, I would like to know what the state of his liver and infection is, and I'd like to know what his renal function, blood count, and his diabetes control and all of those things are. So I'd like to know where his liver's at and where his general health is at, you know?
Yeah.
So here we have the results, and let's break this slide down. On the right, we've got his serology results, and this does confirm chronic hepatitis C infection. Good, he's HIV negative, and he has past resolved hepatitis A and B. So he doesn't need vaccinations, and he doesn't have HIV as far as we know there. We've got a negative test, but he does have chronic hepatitis C. We've got genotype 3A. Now, on the left are his biomarkers that do indicate a few issues. So his diabetes control is not too bad. His cholesterol's not ideal. The alpha-fetoproteins normal. But Joe, could you comment on his blood count and biochemistry there?
Yeah, look, on the full blood count, I think the thing that stands out is that low platelet count. So we should really be seeing that to be comfortable that there is no cirrhosis greater than 150. And his platelet count's coming in there at 129. So that could represent portal hypertension, splenomegaly, and sequestration of the platelets in the and consumption of the platelets in the spleen.
Yes.
Look, his creatinine's okay, and certainly his EGFR is acceptable. But looking at the liver function test, his albumin's borderline at 36, so it's a little on the lower side, but still normal. And you can see that he's got a significant hepatitis, and that AST to ALT ratio is, it's not the 2-to-1 that we see with alcoholic liver disease and cirrhosis, but they are significantly elevated. I guess of concern too in this setting is the elevated GGT, and that does make me think hard about alcoholic liver disease as well as fatty liver disease, and he's definitely at risk of both of those.
Isn't he?
From the basis of his history.
Yeah, definitely. He's got the obese abdomen, he's got the diabetes, he's got the metabolic stuff, and
up to 240 grams of alcohol.
And then the hepatitis C. Wacko, hey. Yes. So, so the factors contributing to his abnormal LFTs.
Yeah.
Yes.
So, I mean, as we discussed, I think
yeah.
we've confirmed that he does indeed have chronic hepatitis C,
Yeah.
and we're also asking questions about whether he has non-alcoholic fatty liver disease as well as alcoholic fatty liver disease.
Yes.
So
Yes.
yeah, and there's been some suggestion of cirrhosis on the basis of the blood test that we've seen so far. So I think we need to kind of look into that as well.
Yeah. Okay. So we should go ahead and think about how we're going to assess his liver. Okay, so again, look, it's back to basics. It's really a good physical examination. We've taken the history. We know what the risk factors are. We're looking for ascites, peripheral edema, muscle wasting, spider nevi, palmar erythema, jaundice, hepatic encephalopathy. I hope it's not that. That's quite late. But, other things, we've been through that as medical students too, and, you can feel the parotids and does he have gynecomastia or other things like that. So the AST-ALT ratio greater than 2 is suggesting...
Yeah, can suggest alcoholic hepatitis or cirrhosis, things that I'd think about.
So we mentioned the lower platelet count.
Yeah.
So an enlarged spleen due to portal hypertension. Yep. Now, an ARPRI.
Yeah, so moving on to those the non-invasive assessments to help build that picture of cirrhosis, whether that's present or not. Yeah,
so you're looking, does he have an ARPRI greater than 2, FibroScan greater than 9.5, and on an ultrasound?
Yeah, and also I think being clear about the cutoffs here in the recommendations. So the APRI of greater than or equal to 1 is when we start to think about cirrhosis. Less than 1, we're very happy it's not present. But the higher we make that number, the more likely cirrhosis is. But what we're looking for in general practice is an APRI of less than 1 to feel safe that there is no cirrhosis. Okay. And in the FibroScan, we're really using that cutoff of 12.5 kilopascals for cirrhosis. And ultimately, the question we're asking in general practice is cirrhosis present or absent?
Okay.
And then the ultrasound, as we said, can help with findings of splenomegaly, a dilated portal vein, and nodular liver surface and things like that. Can build a picture of cirrhosis.
Well, bearing those things in mind, let's have a look at his ARPRI score.
Yeah, so look, the APRI score, again, given the information that we've got, is not a surprise, and it comes in at well over 2. So that's a pretty clear indication that he, or very suggestive of cirrhosis. So, in a meta-analysis of 40 studies, investigators showed that an APRI of greater than 1 had a sensitivity of 76% and a specificity of 72%. And those ratios increase as we go above 2. So I think we've got enough information there to suggest cirrhosis, but we can utilise other tools.
But there's more, yes.
Oh, there is.
Yes. Yeah. Okay, so we got him a FibroScan too.
Yeah,
look at that.
15.9 kilopascals. I think that's a pretty safe bet that this gentleman has cirrhosis. And the FibroScan is a really good tool at telling you whether a liver is normal or whether the liver is cirrhotic. So if you're getting readings much less than 7, the high 6s, that's very reassuring. And once you're hitting over that 12.5 kilopascal mark, you can be that is very suggestive of cirrhosis.
Okay, and just to make sure.
So we did that ultrasound, and we've got a large liver, so 17 centimetres span, a bulky spleen, so no clear-cut cirrhosis, but there are suggestions there that he might have cirrhosis. But the portal vein was normal, so not dilated, and pleasingly, there's no liver lesion there, so we've excluded hepatocellular carcinoma.
Yep. Okay, so we can summarise what we know about Joe, the Italian builder who was found to have hepatitis C in his workup for coronary stenting. He looks like we have decided that he has cirrhosis. There's enough evidence to suggest that he's at least got early cirrhosis. So, and he's got other liver comorbidities, some fatty liver and the alcohol use and other medical risks, but no co-infection. He's on several medications. He's had no previous hepatitis C treatment. But cirrhosis screening and specialist care is definitely indicated. So the treatment options for him, he should be referred to a specialist, and that doesn't mean that I just go, okay, great, that he's got a lot of other comorbidities, and it'll be important that I see him regularly too to keep his diabetes under control and other things, and assist with adherence and referrals and things. But
let's see what happened to Joe. So he was referred to specialist care given the finding of cirrhosis for ongoing management based on that assessment by the GP. He was diagnosed with compensated cirrhosis, so Child-Pugh A, so as you said, early cirrhosis.
Yep.
HCC screening obtained prior to treatment showed that there was no evidence of hepatocellular carcinoma, and that's a really important thing.
So that was the alpha-fetoprotein and the ultrasound.
Yep. That's right. So he was treated with 12 weeks of Mavorite, which is the glecaprevir and preventosvir. There's a bit of a typo there, sorry. And he had the 12-week course. So just a reminder, we discussed on the previous case that the gentleman was eligible for an 8-week course given his absence of cirrhosis. But definitely in the setting of cirrhosis, 12 weeks of Mavorite is indicated. He underwent a gastroscopy, and this demonstrated grade 1 esophageal varices, which didn't require any banding. So he's been scheduled for a surveillance gastroscopy at 12 months to see if there's any progression there. He had his statin treatment suspended while he was on the Mavorite, and this statin was recommenced upon HCV treatment completion, given that concern about the drug-drug interactions that we can see with statins and Mavorite. He had no issues on treatment, sailed through, and was cured. Had an SBR confirmed 12 weeks following treatment completion.
No, that's great, isn't it? That you can get that. So now my role in sharing the care with you, Joe. So he's had a sustained viral response, a cure, but I would be coordinating his 6-monthly specialist reviews for his screening with the ultrasound and the AFP. I'd facilitate the repeat gastroscopies. He'd obviously need assistance to stop drinking.
That's a really important, because we can get rid of the Hep C, but there are other liver diseases that could lead to his cirrhosis progressing and developing decompensated cirrhosis.
Yes. So, and diet, activity, all of those things, so he can get rid of some of that abdominal obesity and his diabetes control. Aiming for a weight loss of at least 10% and improving, all his other metabolic risks will be really important. So this is a bit of a specialist line.
And I think this is one of the critical points of that pre-treatment assessment, because it does dictate how we manage these people after SVR. So patients with advanced fibrosis, without advanced fibrosis, you follow up them the same as if they were never infected with hepatitis C.
Yes, because you've cured the infection, they don't have fibrosis, so yes. Unless there's a risk, you don't. You just treat them as
So it's a durable cure.
Yes.
But in patients with cirrhosis, you can't forget about them because they need ongoing surveillance for liver cancer. The liver cancer risk has dropped, but it hasn't gone down to zero. And so that 6-monthly abdominal ultrasound and serum AFP is really important. And then the endoscopic screening and surveillance for esophageal and gastric varices in patients with cirrhosis is really important.
Yes.
And should be facilitated through specialist care. And I think the other thing to remember about follow-up is that, Hep C eradication is durable, but people can be reinfected. And if there are risks for reinfection, we should be assessing those patients with at least annual HCV RNAs to assess for reinfection. And we also need to look at other liver diseases in patients with persistently abnormal liver function tests after achieving an SVR. So you can't quite hang your hat up if you eradicate the Hep C and the LFTs are still abnormal. To look for other comorbidities.
Okay, right.
Oh,
Oh,
spin around.
yes.
Okay.
There it is.
So recommendations for HCC surveillance after cure. We didn't make these up. Patients, international guidelines suggested that patients with advanced fibrosis, so F3 or F4 fibrosis, as per the American and infectious diseases guidelines, patients need to have 6 monthly ultrasounds and serum AFP. With those that have unclear cirrhotic status, with comorbidities like diabetes, alcohol abuse, and fatty liver, and in patients of older age, you can think about enrolling them in the surveillance program as well.
Right, yes. Okay, fair enough. Okay. So, look, I hope that was clear. He was a cirrhotic man, so you're sharing care there with the specialist. Now we'll go on to our third case, who is 2. Now, this lady is 32 years old, of Vietnamese background, and she was discharged from hospital 7 weeks ago, where she was admitted for septicemia associated with injecting heroin. She was commenced on methadone during the admission and is now dosing at a public clinic, and admits that she has injected on 2 occasions since discharge. Now, she was diagnosed with hepatitis C while in jail several years ago, and had 48 weeks of pegylated interferon and ribavirin for genotype 6, and she achieved a cure after that treatment. She has a history of schizophrenia and has had several psychiatric admissions. Her most recent one was for psychosis 5 months ago, when she was commenced on paliperidone depot. She's been homeless and living in shelters when she can. While she was an inpatient with sepsis, she was diagnosed with hepatitis C reinfection. Sounds very complicated. There's several challenging issues that already stand out. She's still injecting drugs and has a recurrence of hepatitis C. She has had past treatment for hepatitis C, but not with direct-acting antiviral, so I'll keep that in the back of my mind. There are social, housing and mental health issues, and she's 32 and of childbearing age. I can see a GP management plan coming on. So there's a lot to think about there. So let's continue on with this story. Now, she has a caseworker. That's useful. That might be a drug and alcohol or a mental health caseworker. She feels that she's stable and should be considered, has brought you in because she thinks that 2 should be considered for hepatitis C treatment. The schizophrenia is currently well controlled. She is attending the methadone clinic daily and has only missed 1 day over the past month. She has just found accommodation in a shared house near the methadone unit, and she has made recontact with parents and a younger sister, and she wants to have the new treatment as her friend was cured with hepatitis C and the new tablet. So, Jo, should she be considered for treatment? There's a lot to think about.
There's a lot to think about, but I think she's addressing a lot of those issues that would make us concerned, and absolutely, I think she should be considered for treatment.
She certainly sounds motivated to do it, and it looks like she's got some support there. So now she still admits to having had injected a couple of times since she was started on methadone. Is that a barrier to treatment?
No, absolutely not. I think thinking about the injecting drug use as a relative contraindication, it's certainly not an absolute contraindication. Sometimes people that are still actively injecting can have very chaotic lifestyles, and you'd be concerned about compliance issues. But otherwise, it is not a
no
contraindication.
No, so we should be offering it treatment to all people with chronic hepatitis C. We need to reduce its incidence in the community, and her comorbidities are actually not so uncommon. We see people with combined mental health and drug use issues, and social risks and things like that can come along with those. The risk of reinfection and of missing doses are important to consider, but you can enlist the help of caseworkers and other supports. So it's important that safe injecting education is given, that that there is that drug and alcohol support, and making sure that there is good adherence to ensure the best treatment success in somebody like this. So we know that her mental health stability has improved. We know that she's getting the regular methadone dosing. She's only missed it once in the last month, and she is getting her depot injections. There's, you could consider, if she is attending for the methadone, that she could have the treatment dispensed with that. So there's all those sorts of things to consider. So no, she should not be denied treatment. Okay.
And there's good evidence behind that as well. So active injecting drug use is not a contraindication, because the evidence has shown from studies on the needle and syringe programs in Australia that the hepatitis C antibody prevalence is declining, and in the last 12 months, Hep C treatment uptake's increased from 1 to 3% up to 2015, and increased to 22% in 2016, and again to 36% in 2017. And treating this population is really critical to our national goals of eradicating hepatitis C in Australia.
Yes.
And sort of reducing the viremia in this community and transmission. So studies, a meta-analysis of 38 studies, including over 3,500 participants treated for hepatitis C with direct-acting antivirals with a history of recent injecting or non-injecting drug use, or on opiate substitution treatment, demonstrated complete compliance or successful completion rates exceeding 97%, which is impressive, and overall SVR or cure rates around 90%. So very, very close to what we'd expect, to a value of 95% in a non-injecting or OST.
Yeah, so we're saying there's level 1 evidence that there's no reason not to treat people who are still injecting. Yes, excellent. Okay. So we need to assess too prior to treatment. So what sort of assessment?
What does she need?
Yeah, all right. Well, I think we go back to what we know, about we need to work out what her viral load is. We need to work out what the
co-infection status is. She's got risk factors for other bloodborne viruses. So this is something we've really got to be clear about that.
I'd like to know she's not pregnant. Does she? What are her liver function tests? So all of those things. So it's your serology. Again, we've got the stuff on the right there, the serology. And on the left, we've got those biomedical sort of biochemical parameters and things that we need to look at. So what have we got here? So we examine her. She's got a good blood pressure and a good BMI. Her blood count and platelet count and everything look good, don't they? She's got a good renal function. Now, her liver function tests are a bit out, aren't they?
Yeah, so the ALT is up a bit, the AST and GGT slightly, but otherwise we're looking okay.
The AFP is normal.
Yep.
Okay, so hepatitis B core antibody positive. So she's had previous hepatitis B
and cleared it.
And she's a surface antibody positive too, and she's antigen negative, so that's good. HIV serology is negative, and she's had past hepatitis A, and she's immune. And she's not pregnant. Okay, so the caseworker has provided us with the Hep C RNA and the genotype, which is 3A.
From the hospital.
Okay,
admission.
Excellent. Okay, so we've got all of that information. So now, look, we know she's got abnormal liver function tests, and we know that she's got hepatitis C again, so we need to work out the status of her liver.
That's right.
So here we go.
So we've got access to FibroScan, absolutely.
Yep.
And we've got a reading of 6.2 kilopascals, so very reassuring.
In the green zone?
Yeah, in the green zone, that she has a no or very, very early fibrosis. So definitely not cirrhosis. So happy with that result.
Yeah, good. And we know we're going to use our calculator for the ARPRI.
So we've got a score there of 0.526 and
less
than 1. So again, very reassuring that there is no cirrhosis.
Okay, so we've examined her, we've checked the bloods, we've done the fibrosis assessment. So what we now know about 2. Okay, so she was reinfected in 2017 during that septicemia, they found out when she had septicemia that she had a reinfection. She's got type 3A. She's got early or minimal fibrosis. There's no liver comorbidity that we know of, no co-infections. She's got the other comorbidities, though, of schizophrenia and some ongoing intravenous drug use. The medications are paliperidone and methadone, and she has had previous non-direct acting antiviral treatment, and she does not need cirrhosis screening. So the negative pregnancy test is reassuring, but I note she's not on contraception, so we might have a look at that later.
And look, I just want to raise a question's come through asking if the APRI is normal, do we need to go on and do a FibroScan? And it's a good point. You definitely do not need a FibroScan. We just wanted to use the FibroScan and APRI as to reinforce the message about fibrosis assessment. So we understand that FibroScan is difficult to obtain in some areas,
yes.
And you can combined with your history and examination and your assessment with imaging and the APRI, that is sufficient to determine whether somebody has cirrhosis or whether
yes.
you're sufficient cirrhosis. So utilise the tools that you have available, but you do not have to have the FibroScan.
Okay, thank you.
In regards to FibroScans, Joe, there was a question that had come through earlier asking if GPs can request FibroScans.
Absolutely. We're seeing them in many different states. So you can have liver clinics offering that service as a standalone FibroScan clinic, and many imaging centres around the state now are offering FibroScan as part of their assessments as well.
Yes, I know that at RPA they do them for people who are being worked up for hepatitis C, and GPs can refer for that as part of the assessment.
And in community and private radiology places, you'll often find unsolicited FibroScans as well.
Yes. Okay, so here we have this.
So we wanted to go through two prior infection results, and because a few genotypes have bounced around this history, and we did confirm that she had a genotype 6 infection in 2001 and cleared that with a 48-week slog of pegylated interferon and ribavirin. And she was definitely cleared of that infection with blood tests at 6 months, which was how you assessed cure at that time.
Yes.
Given that she's been diagnosed with hepatitis C in 2017, it's very suspicious that it's a reinfection with another genotype rather than recurrent or failed treatment.
Yes,
so because we're looking at those two different genotypes.
Yes.
So just interpret those results as this is a new de novo infection.
Yeah, we're just starting again, aren't we?
Yeah, that's right.
Yes. Okay, so we're going to consider her treatment options.
Yeah, so we again would turn to the GISA consensus statement wall chart. She's got she's eligible for those pangenotypic.
She's type 3A, so she's the first two.
Yeah, so we've got the Epclusa and the Mavorite that are available there. Given that she's non-cirrhotic, we could use the 8-week regimen of the Mavorite or the 12-week regimen of the Epclusa. She doesn't qualify for the elbasvir and grisoprevir or the Harvoni, given her genotype.
Well, if I was looking at that, I guess, I know I'd have to look at the drug-drug interactions, and I'd be looking at that, but I'd be thinking, gee, it'd be great if I could get her through the 8 weeks because of her adherence problems. How do we encourage it? We've got to think about this.
And particularly in this setting, in this patient.
Yes. So, look, we'll look at some of the things. So it looks like she's motivated. She wants to try this treatment. So, luckily, the medication is tolerable. And she looks like she's getting some social support. The schizophrenia appears to be, we're told, is under good control. She's got a caseworker there, so she's getting those supports. We want a regime that's not too complex, and these are just a daily dose.
Daily dosing,
So that's really good. That could be done with the methadone if we could work out something like that.
Yeah. So the Epclusa is 1 pill a day, so it's a fixed dose combination pill, and the Mavorite is 3 pills that are swallowed at the same time.
Yes. continuity and the systems of care and access to care, and the frequency of follow-up, office visits and blood tests. Well, that's really good now, because with new guidelines,
the monitoring is much more straightforward. Yeah.
Okay, so
I just want to address one of the questions that have come through, and it is a really good point, asking about her treatment experience with the pegylated interferon and ribavirin. So given that she's not DAA experienced, so she hasn't been treated with the new medication, so we're not thinking about DAA resistance in this setting, it's appropriate to proceed with treatment in general practice.
Yes.
So it's DAA experienced patients that we need to worry about. We didn't have anything to treat them with in Australia until the 1st of April, so just a few days ago, when Vasavi was put on the PBS, which won't be able to be used in general practice because it's purely for a population that has at risk of DAA resistance.
Right, okay, yep. So we can treat her in general practice because she is still DAA treatment naive.
Yep.
Yes. So here are some other ways that we can look at. These are adherence strategies that we can use, social and peer supports. And she's got a family back in her life now, so that's great. An establishment of a routine. Well, remember, she's having the methadone program. If we can link her in with that, directly observed therapy, again, at the methadone clinic or pharmacy. Good communication with the treating doctor, discussion of adherence, barriers and potential solutions. Look, I think if somebody's motivated, that's a great start, isn't it, to talking about those things. And we're obviously aiming for 100% adherence if we can get it. And you'd be, and it's certainly her history does not tell us that we shouldn't aim for that anyway. I think she's got supports, and she's been attending the methadone clinic, so I'd be hopeful that we'd make a good fist of that. There's some great references at the Department of Veterans Affairs and on the hepatitis websites that you can look at in the end to look at those adherence strategies. So treatment planning for two, we would need to counsel her that as far as we know, 100% adherence is going to give her the best chance of a cure. And she wants a cure. She's excited about the prospect, it sounds like. We'd enlist the support of the mental health worker. Now, we'd have to address contraceptive practices. And whether that would be by injecting long-acting contraceptions or a pill, that would be a discussion that we'd need to consider also with her direct acting antiviral, and whether there's going to be...
Might influence our treatment choice,
Yes. And looking at combining it with daily methadone.
Yeah, and that combination with the observed daily dosing of the methadone is a really great way and a neat trick to facilitate compliance and take some of the stress of managing the medications from patients that have so many things on their plates.
So look, we should look at drug interaction.
So let's pull out the Liverpool website.
Yes.
So we've punched in her current medications, the methadone and paliperidone, and her two treatment choices, the Mavorite and the Epclusa. Now, you can see that there's a little warning sign there of a potential interaction with paliperidone, and that's certainly not a medication that we want to mess around with, given that it's served her so well in stabilising her mental health problems. So, and then also thinking about her contraceptive options, she would not be able to be treated with an oral contraceptive with Mavorite. So, yeah, I think sofosbuvir and velpatasvir would be a good treatment choice. So, we've chosen Epclusa, and what sort of monitoring would we require for two?
All right. Well, look, we know that we don't have to check her liver function tests during the course of treatment, but it'll be important to support and keep a clinical eye on her and check on symptoms, adherence to medication, ask about injecting and sexual activity. But in terms of the actual hepatitis C monitoring, we can wait 3 months or 12 months after 3 months or 12 weeks after she's finished treatment, and we just check her liver function tests, and we check for a sustained viral response. So we check the hepatitis C PCR.
Yeah. So at that 3 month post treatment completion follow up. these are her findings. So she too had reported that she had minimal side effects on treatment. She had a bit of fatigue and headache at the initiation of treatment, and those symptoms wore off with time. And that is what we see commonly. Rarely do we see side effects, but this is a similar story that you might expect to encounter.
Yeah. So she injected amphetamine and missed one dose.
Yeah.
So does this have an impact on treatment success? What you're seeing
here? Missing one day is not going to be a huge deal, and there's been a question that's come through online about missed doses, and obviously we try and maximise compliance wherever we can and stress 100% compliance, but we don't need to be too concerned about dropping off a few days here and there. Just instruct patients never to double dose and just continue until completion. Okay? So if they're finishing a day later or a couple of days later, that's what you'd recommend. The injection of amphetamine, I think with this injecting behaviour, we're using that opportunity to discuss injecting practices and make sure we're reducing her risk of reinfection. But there, that's no other concern there. So in terms of people who inject drugs or who are on opiate substitution treatment programs compared to those that are not, we know from the evidence that treatment adherence rates are similar. We know that SVR rates are similar, and we also know through good data that reinfection rates are low. So, I just don't want people to be too concerned or frightened about addressing treatment in this population.
Yes. No.
And it's that duration of infectiousness that drives transmission amongst people who inject drugs. And we know that those people with chronic hepatitis C are infectious until that virus has gone from their blood. So to reduce viral transmission, we want to reduce the number of contacts and reduce the probability of transmission per contact, recommending the use of safe injecting equipment and regular testing within the drug-using networks. And we want to reduce the duration that a patient is infectious to others. And this is the only way that we're going to be able to eliminate hepatitis C.
So getting more GPs out there testing.
Absolutely, it's critical.
And treating.
It's critical.
So, in summary, we're encouraging GPs to test all patients with risk factors. Test for the hepatitis C virus to confirm current infection, and then follow through with your genotype and your baseline tests, including testing for other more comorbidities and co-infections. You can treat people with chronic hepatitis C, but refer those with cirrhosis, renal failure, or co-infection with hepatitis B or HIV to a specialist. There's a great tool for evaluating for direct drug-drug interactions. And that will help you select an appropriate treatment regime. And it's important to assess adherence and to encourage adherence right through the treatment. Get approval from a specialist to prescribe for at least 10 times or until you're really confident and experienced in hepatitis C treatment, and check. They'll have treatment for 8 to 12 weeks, depending, and then 12 weeks after that you check for hepatitis C RNA and their liver function tests. So you're checking for, has their liver improved, depending on their comorbidities, has it gone back to normal, and have they got a sustained viral response or a cure. Tailor the follow-up according to the treatment outcome, the liver disease stage and reinfection risk. So patients with cirrhosis need ongoing lifetime surveillance for liver cancer, and retreatment should be offered to people who become reinfected. In summary, treatment for most patients is straightforward. It's becoming more straightforward all the time. Refer to the Australian Guidelines for the Management of Hepatitis C Virus Infection, a consensus statement 2018, for current treatment regimes. It's an easy read and it's very clear. There's a handy 2-page treatment checklist on the GISA website, on the GISA site, and on your table. If in doubt, consult with your local specialist and consider further training. Enjoy the miracle of curing hepatitis C in your practice. So we hope that the learning outcomes have been met, to order and interpret tests necessary to diagnose hepatitis C and prepare patients for treatment, to recognise the risks, signs and symptoms of liver disease and other comorbidities that require management or referral to specialist care, and to choose appropriate hepatitis C antiviral therapies according to virus genotype and the potential for drug-drug interactions. Ooh. I'll go back to that so we can think about it. So that's the end of the webinar. I hope it's all clear.
That's great. Thank you, Jo and Mari, very much. We are up to time. There is just one question that we got very early on in the Ahmed case that I just wanted to flag. Someone had asked, with self-imported DAAs for Medicare and eligible patients, are these medicines okay?
Look, it's a difficult question to answer because we don't know, and I don't think it's really relevant in Australia because access is open. All you need is a diagnosis for hepatitis C, and you qualify for PBS-listed medication. So I would just encourage people to use PBS-prescribed medications.
Perfect. Well, that does bring us to the end of the session. So thank you again to Jo and Mari and for everybody who's joined us online. We hope you enjoyed the session and we hope you enjoy the rest of your evening.